All right, welcome back. So in this part of our series on BPV, we're really getting hands-on. We're going to master the two essential bedside maneuvers. And trust me, when you get these right, your diagnostic accuracy for this super common cause of vertigo, it becomes pretty much unbeatable. So let's dive right in.
And I'm not exaggerating here. This is all about building a seriously powerful, high-yield clinical skill. By the time we're done, you'll have the framework to confidently nail down a BPV diagnosis right there on the examination table, a lot of the time without needing any fancy imaging at all.
So here's our game plan. First up, we're going to perfect the Dix-Hallpike test. Then we'll move on to the supine roll for those times when the Dix-Hallpike comes back negative. And maybe most importantly, we'll finish up by learning how to spot the red flags that tell you, hey, this isn't BPPV at all.
Okay, let's start with the absolute workhorse of BPPV diagnoses. The Dix-Hallpike test is your go-to for identifying posterior canal BPPV, which is by far the most common type you're ever going to see.
Okay, precision is absolutely key here. So, you start with your patient sitting up, you're going to turn their head about 45 degrees towards the side you want to test, get a good supportive grip on their head, and then in one smooth but quick motion, bring them down flat so their head is hanging about 20 degrees off the end of the table. And now comes the most important part. You just watch their eyes, and you wait.
So, what are you actually looking for? This right here, this is the classic signature, the pathognomonic sign of posterior canal BPP. First, there's going to be a little delay, a latency of a few seconds before anything happens. Then, the nystagmus kicks in. It'll be upbeating and torsional, kind of twisting towards the affected ear. It's also really brief, lasting less than a minute, and it fatigues, which just means it gets weaker if you do the test again. Recognizing this specific pattern is everything.
And why is it so important to master this one single test? Well, because it's going to correctly diagnose up to 90% of all BPPV cases that walk through your door. It's an incredibly powerful tool for such a common condition. This flowchart just maps out your clinical decisions perfectly. If you see that classic positive result, that delayed, upbeating, torsional nystagmus, boom, you've confirmed posterior canal BPV. If the test is negative, you just follow the path to your next step, the supine roll test. But check out this other branch. If you see any kind of atypical nystagmus, that is an immediate red flag. You need to start thinking about a central cause.
All right, so your Dix-Hallpike was negative, but you still have a high suspicion for BPPV. Now we bring in our second key maneuver, the supine roll. This is how we hunt for those less common but still really important horizontal canal variants.
The setup for this one is different. The patient starts lying flat on their back. You're then going to quickly rotate their head 90 degrees to one side, hold it there for up to a minute while you're watching their eyes, and then bring the head back to the center. Give it a moment, then you repeat the exact same thing on the opposite side.
Now with the supine roll, the direction of the nystagmus, well, it tells you the whole story. You're looking for purely horizontal movement. So if the eyes beat down towards the ground, we call that geotropic. And that's usually good news. You know, it points to those free-floating particles. But if the eyes beat up and away from the ground, that's apotropic. And that tells a different story. It could mean the particles are actually stuck to the cupula. Or, and this is important, it could be a sign of a central problem.
And this table just connects what you see directly to what you do. A geotropic pattern points to canalithiasis, those free-floating particles, and it tells you the BBQ roll treatment, which we'll cover in the next video, is probably going to work. An apogeotropic pattern, though, that points to a different mechanism and needs a different plan, like the Guffoni maneuver.
So let's just zoom out and look at the whole algorithm for a second. You can see the clear logic here, right? If your initial Dix-Hallpike for the posterior canal is negative, your very next step is the supine roll. This systematic approach makes sure you don't miss that 10 to 15% of cases that are caused by the horizontal canal.
And now we come to what is arguably the most critical part of this whole assessment, safety. We have to be absolutely sure we are not misdiagnosing a more serious central neurological condition as simple, benign BPV.
So here's the bottom line. Any deviation from the classic BPPV nystagmus pattern we've been talking about is a red flag, period. Typical BPPV has a very specific signature. If what you're seeing doesn't match that signature, you have to suspect a central cause.
First red flag, timing. Remember that classic little delay in BPPV? Well, if the nystagmus starts the absolute instant the head gets into position, with no latency at all, you should be concerned.
Second red flag, duration. BPPV nystagmus is short and sweet, and it gets tired.
If you see eye movements that just keep going for over a minute and don't seem to weaken at all with repeat testing, that is not BPPV.
And red flag number 3 is direction. Look, if you see purely vertical, downbeating nystagmus, or a nystagmus that actually changes its direction, alarm bells should be going off. Those patterns are highly suspicious for a lesion somewhere in the brainstem or cerebellum.
And when you do see these red flags, you need to act immediately. As you can see here, any of those atypical nystagmus features are an absolute indication for urgent neuroimaging. The same goes for any associated neurosigns, like a new headache or severe ataxia, that's a lack of muscle control, that just seems way out of proportion to the vertigo. This patient needs an MRI and fast. Okay, let's recap the big points. For the Dix-Hallpike, you're looking for that specific combo: upbeating, torsional, latent, and fatiguing nystagmus. For the supine roll, it's all about telling the difference between horizontal, geotropic, and apotropic nystagmus. And for both tests, any weird feature, especially that downbeating nystagmus, is a huge red flag that means you need to dig deeper. So, we've nailed the diagnosis. What's next? Well, in our final video, we get to the fun part: treatment. We'll walk you through exactly how to perform the EPLI, the BBQ roll, and the Gufuni maneuvers to actually fix the problem. And then we'll talk about how to safely discharge these patients.
So I want to leave you with this question to really think about. Now that you know how to precisely identify these nystagmus patterns right at the bedside, how does that change your confidence level when you're making that call, deciding whether a dizzy patient can safely go home?
Thank you so much for watching. To explore more topics on dizziness, vertigo, and imbalance, and to get your hands on more great resources, please visit our website at australiandizzinessclinics.com. And hey, don't forget to subscribe to our channel so you don't miss the final part of this series.